Hi, everyone. This is Stephanie with the Patient Story, and I am hoping that you're doing well wherever you're joining us from. I'm really excited. This is actually a first of its kind interview for us because it features a rocket scientist. And I know that that's kind of a little joke that you've heard before. So I'll welcome without further ado, Praneeth Sudalagunta, Ph.D., applied research scientist at Moffitt Cancer Center. So welcome, Praneeth.
Oh, thank you for having me. I'm really happy to be here and then talk to you today.
Yeah, and there's a lot to get through. And the reason why I introduced you as a rocket scientist is, I mean, you do have a background that would, signal that to people. But I'm excited because this is sort of a different angle we're talking about. So usually, we're talking to, as I'd mentioned, patients and people in that area, and then also to a lot of specialists. So myeloma specialists, right? People who are studying and researching it, as well as treating patients in the clinic. You come from a different background. And so the way you're studying to help myeloma patients and their families is very different. It's unique. And that's why I'm excited to dive in. But, and what you're studying these myeloma cells and plasma cells and everything in the lab. And what drew you to be a scientist at a cancer center, right? Because you could do this in a number of different settings.
Yes, and that's a fantastic question because there's actually an anecdote that I usually tell people because I do get this question a lot, especially because of the transition that I've made from aerospace engineering to cancer research. And a specific setting is basically when I'm taking an Uber ride, and then the Uber driver, you generally make small talk, and then they ask, like, what do you do? And then I say, I work at a cancer hospital. And then here at Tampa, Moffitt is kind of like your neighborhood cancer hospital. Everybody knows Moffitt. And then the moment I say that I do cancer research, there's usually like a 3 to 4 second pause, and then there comes like my mother, my brother, my uncle, my father, like somebody. Everybody knows somebody who has cancer, and that hits them at a very personal level, and that is something that is incredibly compelling about working at a cancer center because it puts you literally close to patients, and you have access to patient data in a way that maybe a research facility at a university may not have. So I think that's what's really exciting about being at a cancer center.
Wonderful. And yeah, it's so true, right? Everyone, unfortunately, it's like there are very few degrees of separation. Lots of people who are, impacted in some way by cancer. So, and I had non-Hodgkin's lymphoma, blood cancer. And so very grateful for any research that's happening in this space. And, you and I agreed that there's a need to translate this medical scientific jargon into understandable, digestible information for people. So we have this established. We know that myeloma is not curable right now. There is no cure. But what we do know and why we have so many of these series now is because there's so much going on in the landscape of myeloma drug research. And a lot of that in combination, which we'll talk about later, right? It makes it tricky to understand how people are really responding to a particular drug. And that's where you come in.
Sure. So basically, when you have a newly diagnosed patient who has never seen any therapy, they typically respond to the frontline therapy that they get. And what happens after that is that once they relapse to that, it basically happens at some point. For some patients, it's very quickly. For some patients, it might take a while. But whenever they do relapse, it's kind of all bets are off, really, like because you really don't know what they get, and then as they keep relapsing, the complexity keeps increasing exponentially because now you have different sets of patients who have received different different treatments and different sequences, right? And a lot of patients we've noticed that over the several lines of therapy develop what we refer to as multi-drug resistant state, which basically is that they might have been exposed to like four or maybe four lines of therapy, and then they're all of a sudden refractory to like 20 drugs, right? And this is something that we are able to figure out because what we have is what was developed here at Moffitt Cancer Center by Drs. Ariosto Silva and Shain, whose lab I work in, is that they've pioneered this technology where they take cancer cells, from a patient, which is donated by these patients at Moffitt Cancer Center. And what we do is that we culture them outside the human body, basically in a petri dish, and we basically trick the cancer cells into thinking that they're still inside the patient's body by giving them enough resources to survive. And then we treat these cells with various drugs. And this is incredibly powerful piece of information because this is something that you wouldn't otherwise get in a clinical setting because these patients, they always receive combination therapies. So if a patient has responded, you don't know if they've responded to one particular drug out of the three drugs that they've received, or is it like a combination of two? Like you have, you basically have six possibilities. So that's kind of why this platform that was developed here at Moffitt Cancer Center is so powerful, is because we are able to characterize drug sensitivity for a given patient to various drugs individually, and that's kind of what really powers my research project.
And it was so amazing to learn about this because not only, of course, is that data so important, but you mentioned this, you're unable to do it currently. I mean, the way that people are figuring out resistance or sensitivity to drugs, meaning if they respond to a drug, is by having to go into this clinical trial or or just taking the combination if it's already approved, and then figuring out that way, does it work? Does it not work? And that's hard, right? It's hard for people in so many different ways, especially when you're dealing with something that's chronic, this relapsed refractory multiple myeloma population. They are physically going through a lot, and mentally and emotionally, they're not really getting a break. So being able
Right.
to test all these things in a lab, I think, is incredible.
Right now, what we do is that we generate a PDF report for a physician here at Moffitt for every patient who donates their bone marrow specimen. And then we actually have these bar plots which tell like, okay, for this particular combination, this is what the response is going to be like. So there's a predicted response. And then that kind of gives the physician a relative view of, okay, these are the different drugs. And relatively speaking, this is how these drugs respond compared to each other. So that is something that we have also developed.
Okay, great. We'll dive more into this in a bit, but let's rewind a little bit into talking about personalized medicine and predictive, right? We keep hearing predictive, and this is promising for people for all the reasons we mentioned earlier. Can you talk about what it means to identify predictive biomarkers? Like, what are you looking at? And again, you've touched some of this, but how it's being studied in the lab effectively.
Absolutely. So in order for predictive biomarkers, on one hand, we have the readout, which is the drug sensitivity, right? So we have this drug sensitivity for each of the patients. And in order to be able to predict their drug sensitivity, we need to identify a feature in a given patient. Like, for example, let's say if you have, so basically the question is, what are these features? Now, what we rely on is that there are certain genetic features and there are certain other cancers where there are certain mutations, for example, that make a particular patient more sensitive or more resistant to a given drug. And this information is kind of widely known in those cancers. But in myeloma, there's no real baseline for this. So there's really not a lot of data. So there's a lot of potential for improvement. And what we basically do is that we use gene expression data. Now, gene expression might sound like a very absurd scientific jargon term. So I will try my best, again, an aerospace engineer's perspective of what a gene expression is. So let's think about a cell as a factory. Now, every factory produces something. Let's say this factory produces t-shirts, right? And there are other factories that might be producing belts, another factory that might be producing like trousers. And collectively, what they do is they clothe the population, the society, right? And it's kind of what happens inside a complex organism's tissue or an organ, is that you have these different types of cells, and they all are doing their part in making sure that the organ functions in a certain way. But sometimes when there is a particular type of cell that's not functioning as expected, which is typically what happens when that particular cell turns malignant, is that you kind of have a supply chain issue, like something that we're all experiencing right now. Like you have basically what happens in that organ is that you have too much of something, and that relatively you have too little of something else. And that's basically what leads to potentially organ failure, and it could be very catastrophic. Now, let's zoom into what happens inside the cell. Now, the cell, like I said, is a factory, right? Now, this factory that makes t-shirts, it basically has something kind of like a family recipe. Like it's kind of like your grandma's recipe for biscuits or something like that. So it's basically hard coded and written into a giant vault, which is called the nucleus. And this family recipe is basically the DNA, right? And then on the factory, the floor of the factory, you basically have a lot of machines, right? And these machines are known as proteins. So proteins are aptly termed as molecular machines, and they basically do all the work inside the cell. So you have this giant family recipe that's inside the wall that is locked for, not everybody can walk in there because it's protected. And then you have all these machines on the floor. Now, how does this information, this recipe from the vault go in to these machines? Because these machines need to know what to do, right? Because they need to be a machine that draws the cloth, another machine that cuts it, another one that folds it, and then stitches and then prints. So all this needs to happen in a sequence, and they all have to be done in a particular way because you need to have t-shirts which are bigger, smaller, so on and so forth. So what happens is that these messages are being sent from inside the nucleus using, basically, you can call them supervisors. Like these are managers, these are upper manager level people who have access to the vault. They have exclusive access to the vault, and then they basically send these information down to the factory workers on the floor. And what gene expression really is basically wiretapping that information that comes from inside the nucleus to these molecular machines. And what we do is that before they go into that, we capture that information, just like wiretapping, and then we're trying to estimate what the cell is telling. It's trying to estimate, we basically sequence mRNA, which is messenger RNA, right? So that's what gene expression is. And it's, since like it says messenger, right? So it's basically the messages that are going to these proteins. And that's what we capture. So this gene expression, we capture for over 20,000 genes. So now you have a problem of too many. Now you have 20,000 genes and you just don't know which genes are really important for you. And that is something that we figure out using our approach, is that we try to figure out which genes are actually driving resistance to a given drug and which genes are driving sensitivity to a given drug. And we are able to do that because we have gene expression for 500 patients, and on one hand, and on the other hand, we have the drug sensitivity for all those patients. So we're able to match them, use computational methods, and say, oh, these patterns lead to resistance to this drug, and these patterns lead to this sensitivity to the other drug, and so on and so forth. So that's basically, not in a nutshell, what a predictive biomarker is.
Yeah. Well, it's hard to do in a nutshell for that topic. Um, if I'm hearing correctly, again, boiling it down to the very essence of what you're saying, you're studying the messaging that's happening from the nucleus or the vault to the proteins, which are the machines, the molecular machines, right? And you're capturing this somehow. And some of the messaging allows for a pattern of, oh, sensitivity to a particular drug, and other messaging with a certain pattern shows you, oh, they're more resistant to this drug or something like that. Is that ballpark?
Yes,
Okay.
perfect. Yeah.
Yeah, I mean, it's very interesting because it's fresh eyes, a different perspective with that background, using the mathematical computational models that you have from one field, applying it here. I think that's fabulous. So again, what I'm hearing, you had mentioned the two things. So you're studying the drug sensitivity and the gene expression as part of this research. Those are the two important parts. Now, specifically, first of all, you had mentioned the actual process. So these patients at Moffitt, they were getting bone marrow biopsies, or basically they were getting extractions to get those cells from the bone marrow, right? And that was what's being studied in the
Yes.
petri dish. Yeah. And is the pioneered approach with the tumor microenvironment? So making sure that they would stay alive outside of the body, was that the real?
Yes. So basically, what we do is that we take these cells and we culture them, like I said, in a petri dish. But the actual term is that it's a multi-well plate. It has like 384 wells, and then now we're trying to use like a 1536 well plate where you're able to test 1,536 experimental conditions on one patient simultaneously. So this will allow you to test several drugs at different concentrations. And we overall also need like some replicates, right? You need some technical replicates in case there are any issues, and we need to make sure that if there's any variation to account for that and things like that. So what we do there is that in that well, we basically culture these cells with bone marrow stroma cells. These are basically from the patient's. It's not from the same patient. It's usually from another patient a few months ago or like a few weeks ago, and then we basically capture these cells in a flask and then allow them to replicate, and then we use those cells to kind of give them that microenvironment. It kind of provides them those growth factors to survive, and we also use that patient's plasma, and then we add that into that. So basically, they think that they're still in that microenvironment for them to survive.
Wonderful. Thank you for that. I know that there was a recent, it's ASH, so it's like a huge blood disease, blood cancer conference where brilliant minds gather. And there was a presentation specifically about this kind of research applied to daratumumab and selinexor. And I'd love to hear about that research.
Absolutely. So, like I explained earlier, there are these predictive biomarkers. So what we've done is we've tested 500 patients with 180 drugs that some of them being used in multiple myeloma, but most of them are just drugs that are used in other cancers. And what we did is for these 500 patients, we also have their gene expression data, and we combine the two of them to identify basically like a fingerprint, like a genetic fingerprint for each drug. And we did this for all the 180 drugs. And then what we did is that we were particularly interested in those pairs of drugs which had like an exact opposite fingerprint. Like if there are certain genes which are implicated in resistance to one drug, uh, are those exact same genes implicated in sensitivity to another drug? And then we did this massive analysis with all these 180 drugs. And then we found that daratumumab, which is a monoclonal antibody, anti-CD38 monoclonal antibody that's currently approved for use in multiple myeloma, and selinexor, which is a selective nuclear export inhibitor, also approved for use in relapsed multiple myeloma, is that these two drugs actually have this anti-correlative profile where the fingerprint of one drug is exactly the opposite of the fingerprint of the other. That's something that caught our eye, and then what we did is that we basically reached out to we have an active collaboration with Cardiofarm Therapeutics, so we basically reached out to them and said, in your trials where you're treating selinexor patients, could you look at the treatment history of the patients and split them into patients who have been exposed to a anti-CD38 monoclonal antibody and those who did not, and then compare their survival. And basically what they did is they essentially compared the two. And what we noticed is that in two clinical trials, STOMP and Export 028 are the two clinical trials. And in those two trials, they noticed that patients who received an anti-CD38 monoclonal antibody survived longer versus those who did not. And and that's basically like a clinical validation of kind of an inference that we've made based on completely data-driven approach, right? We did not use any known biological knowledge or any mechanism, none of that. And we just used this data and then we fed it into this computational system. And then it basically spits out this pair of drugs, and we basically go into a trial and see if there is any difference, and lo and behold, we find that difference, and it's kind of a validation that this whole computational approach does work. And that's kind of what the ash talk that you were referring to is focused on.
Wow. So what I'm hearing you say is there's all the computational models, the data that's coming out, and then this was verified by the clinical research data, real world data from patients and how they had performed on the the daratumumab type drugs, so the anti-CD38 monoclonal antibodies versus, or the CD38 monoclonal antibodies. I cannot ever say the jargon. Versus, so because what you're saying is what you'd found with your data was that those with the daratumumab resistance were sensitive to the selinexor, and was it also right? So, and was it vice versa as well?
That's a very good question. So, based on our inference, we expect it to work both ways because we don't know. I mean, it's a correlation, so we don't know of directionality. Since we reached out to Cardiofarm Therapeutics and since they looked back in time, they were able to, because their trials involve selinexor, and they can always look back in time and say whether a patient has received daratumumab or not, right? You could always flip that question and look at a patient who's enrolled in daratumumab trial and see if that patient has prior exposure to selinexor and so on and so forth. But potentially, if it works both ways, we don't know this yet, but potentially as a hypothesis, if it works both ways, you could have a daratumumab selinexor, and once the patient is exposed to selinexor, now they're not. This is something that commonly happens when you expose a patient's cells to a particular drug, they acquire resistance to that drug. So they first were exposed to daratumumab, now they acquire this resistance to daratumumab, and now you treat them with selinexor. Since we know that they're sensitive to selinexor, then they acquire resistance to selinexor. Could you then treat with daratumumab again, right? So basically what we'd be doing is that from a patient's perspective, we would be taking them back in time in terms of the tumor. The tumor would basically go back in time to the point where they were first treated with daratumumab. And that's essentially prolonging survival by that much amount. And could we do this over and over again? Could we do this once? These are all open questions. And this is something that we're actively investigating. But based on our data itself, we don't know of directionality. We just know this much that there is a negative relationship. We just don't know what's the extent of it. And that's something that's worth investigating. It's a very good question.
Yeah, it's fascinating, all of the different questions that this, poses. So if I'm a patient and a caregiver now listening to this, it's like, okay, so now you know that daratumumab resistance, you may respond well with selinexor. So that's one data point that might be helpful. Although I think right now a lot of specialists and physicians are trying to do these different combinations. If you haven't, we'll add this to the next, as the next regimen. What else can patients take away from just that part? And then I'd like to talk about it's so fascinating if you were to able, to kind of do both back and forth.
Basically what happens is that you have daratumumab and selinexor as a sequential therapy. That's what we're proposing. And what we see is that daratumumab is something that's currently approved as further up for patients, as in like in certain cases it's approved for newly diagnosed patients, and it's kind of ahead of selinexor in terms of when it's being treated. And then you have selinexor being approved for early relapsed and refractory patients, and then a previous trial concluded that it was effective for a penta-refractory patients. So essentially, the natural sequence in which we have this clinical pathways at various institutions across the United States and the world is that you have daratumumab ahead, and then selinexor is kind of like trying to catch up in that sense. So in a way, currently, you already have that system where kind of patients do get daratumumab, and they're likely to develop resistance towards it, and then they eventually become sensitive to selinexor. So the potential of having them treated with selinexor, there are certain sub cases in which it's already approved by FDA to have a daratumumab selinexor treatment, but it's not approved for everybody. So it's in a subset of patients.
I just want to be very clear. So one is, according to both your data and also the selinexor clinical trial data, people who were on daratumumab, and then selinexor did better than those, right, who were just on selinexor themselves.
Yes.
So you have that data, okay, which is really important. Then the second question that kind of came up was that needs to be studied is, well, we need to figure out the directionality of it. And could it be, if you could figure out with daratumumab that it's the inverse is true, that then you could do daratumumab, then selinexor, then daratumumab again, and then it's like, well, how many times could you do that to prolong
Right.
survival? Right. And of
Yes.
course, this is all without talking about side effects, and of course, people develop those, and so, but just purely on the scientific sort of level, that would be the line of questioning to follow.
Yes, and that's something that we're actively investigating. So based on our data, like I said, we don't infer directionality, and we're kind of thinking about that, like how could we develop some kind of a computational approach? Can we use a particular type of data set to infer this directionality? That's basically kind of something that we are looking at. Like, could we look at a patient who has the gene expression of a patient before they were exposed to selinexor versus after exposure? Like, can we look at this difference between their gene expression? And what difference does that make? Like, does it basically flip this fingerprint from one side to the other? That is something that we're actively investigating.
Could this then, or so you're actively investigating a lot of different things, and I know you said there were a lot of drugs, but in myeloma, we know like the four major classes of drugs. Then you also have the novel mechanisms of action, like
Mhm.
selinexor. So is there going to be testing like, okay, it's really a function of how these different drugs act, and you'll also test the proteasome inhibitor versus the, monoclonal antibody versus the imids, that kind of a thing.
Yes. So when we look at these drugs, first we look at them in an agnostic sense. We don't really classify them based on classes, because what we know is that drugs which belong to the same class, they sometimes have a different pharmacodynamic effect, which is basically, if a drug has a particular target, how does that inhibit that particular target, and how does that vary across time? That effect, that the targeted effect of a particular drug, that's basically the pharmacodynamics. And the pharmacokinetics is basically, when a patient takes a pill, like, they basically go through the ADME process, it gets absorbed, and, like, so basically you have that drug available at the site of the tumor, and how does that vary as a function of time? So a few years ago, I was reading this textbook just to understand like PK/PD, pharmacokinetics and pharmacodynamics, and then the author wrote a really nice statement which made a lot of sense to me and stayed with me, is that pharmacokinetics is basically what the body does to the drug, and pharmacodynamics is basically what the drug does to the body. So it's kind of like, there's a yin yang effect there, which is really cool for me to remember.
That is really interesting. And so I just want to make sure I'm understanding this correctly. So what that means is it's agnostic to the classes, because while you can say how the drug is supposed to react to the body, we actually don't know how the body will, we don't know the other part of it. So it is very patient specific, and that's why it's personalized medicine. And
Yes,
right.
it's patient specific, but also it's drug specific, because drugs within a class, they behave very differently, and this is kind of known but not very well known in the field. So there's a lot of complexity that's associated with it.
Okay.
Uh, yeah.
That answers my question, because I was basically asking, if you test one class, does it apply to all? And the answer is no. This has to be research that's done with each drug in
Exactly. Yes.
different sequences. Okay. What's the goal? I mean, I know that this study's been ongoing. So it's been 500 plus myeloma patients. That's a great number. What's sort of the next, hallmark moment for the study? And yeah, what are the goals here to expand to the major goals? You talked about some, but what are the next major steps here?
Sure. So basically, right now, the way traditional treatment is given in the clinic is that a newly diagnosed patient comes in, or the patient is early relapsed or refractory or late relapsed refractory. You know where they stand in terms of that timeline, and then those patients are given a certain treatment as per like an established clinical pathway system. And what we want to do with this particular research is that transform that into a predictive biomarker driven decision making system. So basically, when a patient comes in, you're able to identify this fingerprint that the patient has, and that's from the gene expression data. And then we're able to tell that this particular patient would be best suited with this drug and it's not something that's defined by this sort of clinical pathway system. And the hope and what we've shown in our study is that when you do things this way, the patients do survive longer. But like that's what we've showed with the daratumumab selinexor study in a microcosm. But potentially, if you could apply this to all kinds of fingerprints that might exist out there for different patients, you could potentially match them to a drug that they would best respond to. And so you basically have subsets of patients responding to subclasses of drugs, and then you'd kind of have treatment prescribed in that particular fashion. And it's kind of a predictive biomarker driven therapeutic intervention. So that's basically how I would put it for with respect to the next step for this study. Yes.
And a couple follow-ups there. One, you would just need the bone, like a bone marrow biopsy from patients to be able to do this research, right? For the gene expression and
Yes. So that's the cool thing. So what we need here is, since we've already done ex vivo drug sensitivity characterization on a cohort of patients, that's kind of the patient, it's kind of like a training set. And we've learned a lot of things from that training set. So we no longer would need to do that going forward with a new patient. So the new patient would basically give us, would donate their bone marrow specimen, and we would basically get the gene expression data from it. We would not need to do the ex vivo drug sensitivity characterization. And the idea is purely based on gene expression. Could we make a certain, like conclusion in terms of which drug or which particular subclass of drug the patient would be best suited to? And alternatively, what we could do is if we can have cells to be able to characterize their ex vivo drug sensitivity, we can also match drugs. Ex vivo drug sensitivity screening also does the same thing, but in a very different way, right? So even there, you can identify a particular drug that the patient is more sensitive to, just like this fingerprint from the gene expression data does. And what I personally think is that the future is really in a multimodal um, imaging or decision making system, where you basically have these multiple modalities kind of coming together and informing a particular common decision making system. So that's kind of what I would say, that's really where I kind of foresee the future of cancer treatment really is.
which is exciting.
Yes.
I want to clarify just in terms of for patients what they would need. So as a new patient wanting to be part of this, process to see if it would work for them, you're saying you would still need bone marrow cells from the bone marrow, right? But you wouldn't need for them to have to go through a treatment like that data. Is that what you're saying to show the sensitivity or resistance?
Yes. So if we go back to the prime objective of the study is that we have two sets of data, right? Ex vivo drug sensitivity and gene expression. So we have this for 500 patients, and we've used this to inform the model. Going forward, we just use the gene expression data from a patient, and then that just informs the process. Yeah.
Perfect. So that saves the time, of course, a huge amount
Yes.
of time and
And definitely cost, because the gene expression data is something that is a lot more affordable than doing this ex vivo drug sensitivity screening, because it involves a lot of personnel, a lot of equipment, and so that kind of brings up the cost. So you basically be able to do more with less money.
you were mentioning before too about how this particular part of research came about, which actually started with another study looking at four combinations with selinexor and different drug combinations, right? What was the result of that prompted this study, and what are the possibilities with other pairs of drugs?
So basically, we looked at four two drug combinations involving selinexor. So they are selinexor dexamethasone, which is already FDA approved combination. And then we have selinexor pomalidomide, which is currently being studied in the STORM trial. And then we have selinexor ilotuzumab and then selinexor daratumumab, which are also being studied in the STORM trial, because it's a multi-arm clinical trial, right? So basically what we've observed is that in our ex vivo drug sensitivity cohort, in the patient cohort that we looked at, we noticed statistically significant synergy. Synergy is basically it's better than it's not better than one drug. It's basically better than the additive effect. So what is an additive effect? Additive effect is if one drug kills 50% of the cells, the other drug kills 50% of the cells. The additive effect is 75%. One drug killed 50%, the other one killed 50% of the remaining 50%, and now you have 75%. If the combination kills 87%, then you could say that 12% is a synergistic effect. So that synergistic effect is kind of like a high bar when we think about combination therapies. And that high bar was what we used to characterize these two drug combinations. And what we noticed is that out of the four combinations that we looked at, selinexor dexamethasone, selinexor pomalidomide, and selinexor ilotusimab were statistically significantly synergistic. And selinexor daratumumab was synergistic in a subcohort of patients, which was very interesting to us because whenever we see that, we're thinking there is some kind of a predictive biomarker. There is something that is common among these patients that's driving them to be synergistic and not in the other patients. So that is really exciting from a research standpoint. And that's when we really got interested in looking at selinexor and daratumumab as a possible sequential therapy, and basically looking at these predictive biomarkers. And this can be potentially applied to other drugs. And I mean, basically, there's several drugs that are available currently in multiple myeloma. And if you think about the possible combinations, it just basically explodes combinatorially. So, and all of that can be done using a simple computational model, which kind of prunes all these different pairs and kind of gives you this curated list of pairs that you could look at for combination therapy and also for sequential therapy. And this could potentially be tested in a preclinical setting first, and then in a clinical setting. And that's when it would translate into clinical practice eventually.
Yes, which is an important point to make. A lot of this needs to still go into clinical trials, and after that data is when you'd see the practice happening at your healthcare provider. But all this to say that this research is really exciting because you're able to do the studies without having people actually have to go through everything first to get the data.
Right. Yes.
Which again is just so big. If we can save people that stress and that weight of having to endure all of the treatments that they already have to anyway, then I think this is great for not just their survival, but their quality of life. So thank you. So my last question for you is, what is sort of the high level message and takeaway for especially relapsed refractory multiple myeloma patients and their families with this kind of data? Big question, because we talk to a lot of people who do clinical trial research, and it's always, well, how far away is this from me benefiting in real life? And yeah, what's the 5-year, 10-year sort of picture for patients?
That's a great question. And the short answer is so basically whatever study that we're doing right now, we're putting all this information out there. The first step is always to basically go through a clinical trial. And once we go through a clinical trial, because a clinical trial would ensure that it's actually done in a controlled condition and it's basically proven, and there's a lot of thoroughness associated with it. Once it goes through a clinical trial, that's when it's available to patients, for their improving their treatment therapy. So the idea here is to basically put out several novel therapeutic strategies based on these genetic fingerprints that we're trying to capture from gene expression data. And the idea would be matching patients to these fingerprints and then identifying them and matching them to the drug that they would best respond to. And this drug would potentially prolong their survival. So to that particular treatment. And also, this would be done the next time they would have to get treated. So it would prolong their survival then, and the next time, and the next time. So it basically has this compounding effect. And our hope is that when we do this at every juncture through a patient's journey through multiple myeloma, potentially we could extend their survival to maybe like 10 to 15 or maybe even 20 years. And that's at that point it's kind of a new life, and that's kind of the idea behind that.
Well, thank you so much for sharing. This is exciting research. It's so nice to have the aerospace engineer slash rocket scientist, perspective as fresh eyes and fresh knowledge in the cancer space. So thank you for the work you do.
Thank you so much for giving an opportunity to talk about my research. Thank you.
Yeah, and it's Dr. Praneeth Sudalagunta at Moffitt Cancer Center, applied research scientist, Google Scholar. He didn't want me to name all the different things, so I won't. But for our full conversation, please head to thepatientstory.com where you'll find human answers to your cancer questions.